ম্যাডাম আমরা ফেসবুক লাইভে আছি, এখন ক্লাস শুরু করবেন প্লিজ ম্যাডাম।
Assalamu alaikum, namaskar and a very good evening. Welcome you all in today's session. Today we are going to have the first IOE session, which is on emergency station. We all know that emergency station is the station 1, but you all can get any other station as a first station, because there are 5 stations. We all know that. So IOE station is a very important station because we can get lots of marks from there. With a very little effort, we can get so many marks from there. So it's a very important station. And the most important thing is that the structured preparation of the IOE station is very much important, but because we are not concerned about the IOE station in the initial stages, but IOE station is not different from other studies or other parts or written examination format. We have to follow the format. So again, I am welcoming you all in today's session, and I am going to share my screen, and that will be a problem-based and scenario-based session. And our questions, our FCPS questions are going to be more problem-based and scenario-based day by day. We all are going to participate and relevant and important problem solutions from the scenarios. So I am starting my part. Is the screen visible? Screen is visible?
Yes, madam.
Visible.
Visible.
Okay, that's great. Okay. Next. Actually, you all know all the formats, but the basic format, we all know the formats. Actually, there are so many echoes. Can we stop the audio option of the computer? There are so many echoes. Can we all stop the audio options so that we can clearly listen to all the things, and we can also listen from you as well? The basic format. The basic format is the emergency station. There are 5 stations, but in station 1, emergency station can be station 1, 2, and the emergency station 1 pollution, and emergency station 2 is management station, chronic case management, recent updates, public health, and ethical issues. Each station will be problem based. Each station will be problem based, and we can start from any 5 of the station, and the problems are written in the paper in a table, and you have to go through the scenario and start answering the question from next. The examiner, can you hear me? If the sound is clear?
Clear.
Yes, clear.
Okay. So you all know that there is nothing to tell more about this. Next, the formats. Emergency evaluation. What are the parts of emergency evaluation? That will include history, physical examination, investigation, diagnosis, relevant basic and paramedical sciences. Also know this thing. Can you hear me?
এখন
জি,
শোনা
ম্যাডাম,
যাচ্ছে কিন্তু এর আগে খুব সাউন্ড হচ্ছিল আর কি, একদম ক্লিয়ার ছিল না। এখন ঠিক আছে।
আমরা সবাই যদি একটু অডিও অপশনটা বন্ধ রাখি এবং আমরা ফেসবুক এবং জুম এই দুটাতে একসাথে যেন হচ্ছে মানে লগড ইন না থাকি। আমরা হচ্ছে জুমে গেলে জুমেই থাকি, ফেসবুকে গেলে ফেসবুকে থাকি, দুটো একসাথে থাকলে অনেক বেশি ইকো হতে থাকে। তো আমরা ফেসবুক বা জুম যে কোনো একটা অপশনে গিয়ে হচ্ছে আমরা ওপেন থাকি, তাহলে আমাদের এই অসুবিধা হবে না। তো আই এম গোয়িং টু মাই টপিক নেক্সট, ইমার্জেন্সি ম্যানেজমেন্ট। ইমার্জেন্সি ম্যানেজমেন্ট ইস্যু, I have already told that there are two stations, emergency evaluation and emergency management. Emergency management station includes the treatment, rational use of drugs, prognosis, complication, adverse drug reaction, outcome, relevant basic and paraclinical sciences. As we will proceed, we are going to have such examples. What are the paraclinical and basic issues that can be discussed in the IUE station? So it's an emergency. What are the emergencies that are important for IUE station? We all are going to take the preparation from the beginning along with the written preparations, because the preparations are not different, but the format is different. Pregnancy related, oncology, infections related, we must not forget the infection related emergencies, because well discussed infection related emergencies are COVID emergencies, dengue related emergencies, sepsis, malaria, tetanus, strep2 and staphylococcal toxic shock syndrome. These are also emergencies. So infection related emergencies must not be forgotten. GIT hepatology related emergencies are well known, and we are much concerned regarding all these things, because we are going to have all the questions in the written also. Poisoning, very much important. New issues, LSD and YABA, the new issues of concern. Alcohol is already a well discussed issue. So these things must be concerned in preparing in case of IUE. Envenomation and acute medicine, every word of acute medicine, every issue is very important. Respiratory support, circulatory support, Robind Amin sir has discussed the mechanical ventilation related issues, and only critical care medicine fellows or critical or anesthesiologists, they are concerned about the mechanical ventilations and use of it. But I think as a recent update or management of the respiratory issues can be important for us as well, because in case of acute medicine, we are going to start the acute medicine unit under the internal medicine. So these issues should be discussed, and these issues should be concerned with other issues. So these are the important issue. You all can go through it. Cardiology related, so many issues: cardiac arrest, heart block, syncope, hypertensive emergencies, pulmonary edema. Rheumatology related issues, acute visual loss due to optic neuritis, septic arthritis, or RPGN related issues that can come in the emergency management issue. Hepatology related issues are less likely, but we must not forget these things also. Neurology, these are well discussed: seizure, Coda-Icona syndrome evaluation, not management, myasthenia crisis, neuroleptic malignant syndrome. These things are important for problem-based question and IUE also. So these are the important issues. Endocrine, so many important issues: hyperglycemia, HONG, ketoacidosis, Sheehan's syndrome, adrenal crisis, thyrotoxic crisis. So many important issues are there. So we should all go through these important issues. Next slide. Can you, if the slide is visible clearly? If the slide is visible clearly.
Yes,
Okay. There are emergency boxes. So emergency boxes are very important. When emergency boxes are done, then 50% of the preparation of IOE emergency station is done. So emergency boxes, we should learn all the emergency boxes. I'm going to give all the emergency boxes together. And we must learn the emergency boxes because I have to answer the question according the emergency boxes. Although the issues or the management plans that may not go along with our recent management plan, because there are so many things written in the Davidson that are not applicable for our country. But emergency, according to the emergency box, we are going to tell the answer. Next, emphasis on the symptom. Approach to analysis is the key to diagnosis. Emphasis on the symptoms, not emphasis. If emphasis on the symptom, we can reach the diagnosis very easily. So symptom analysis is our main concern. Approach to emergency patient steps. This is a common approach for all the emergency patients, for written, for short answer questions, for problem-based questions, for IOE. This is the format for all kinds of emergency patients and emergency issues. And there is a little bit change in the steps. That is, we used to follow A, B, C, but the recent acute medicine chapter emphasis on C, A, B, control of the obvious problem. If there is any obvious problem, we have to control it first. That if the patient is in seizure, we have to control the seizure first. Next, we have to assess the A and B, airway and breathing. If there is any obvious problem, then we have to solve it first. Next, C, A, B, C, C circulation, D, disability. C, A, B, C, D. So this is the first step. So many echoes. Can you hear the echoes? There are so many echoes. Can you hear me clearly?
Madam, we can hear you clearly, madam. There is no echoes.
Approach to the emergency is a common format for all the things. Control of the obvious problem, airway, breathing, next circulation, next disability. These are the 5 points. We have to write it down, or we have to tell our examiner that is asked. What is the immediate approach, or what is the immediate management plan? What are the immediate steps you are going to do? So the answer will be same. Next, selecting the appropriate location of care. That is, these points are taken from the acute medicine chapter. Appropriate location of care. We have to select the appropriate, the patient will be shifted to HTO with specialized care unit or ICU. We have to select the appropriate location of care. Bedside and urgent investigations. Bedside investigations are very important, because if a patient comes to you with coma, if a patient comes to you with chest pain, the bedside test will decide what will be the plan of care. That is, chest pain, ECG, we can think without ECG. And if the patient comes with coma, we can think that we are not doing blood sugar. So bedside test and urgent investigation, these are the emergency patient management step. That is also an important step. Next, immediate treatment or intervention. Immediate treatment, that can be intravenous, IV line, oxygen inhalation, IV fluids, diazepam, that can be calcium gluconate. Anything can happen with it, that immediate treatment or intervention. Looking for complications and looking for treatment adverse effect. You are giving a anti-snake venom, but you are not prepared for the adverse effect. You are not prepared with adrenaline. Then that is not a good management plan. So if there is a chance of adverse effect, we have to be prepared with that. And monitoring, looking for complications of the disease, looking for complications of the treatment adverse effect. That are the steps that we should follow. So that is common for every emergency patient, and we can follow it in written for also, or we can also follow it for IOE station. Next, I am going to the problems. Oh, there are, I want to tell you that there are 3 formats for IOE station, emergency station, 3 formats. Number 1, that is plain IOE emergency evaluation or management. That's a plain question and you are going to answer the straightforward questions and answer. That is all, that is one format. Number 2, that is emergency station overlapped with another station. Emergency station can be overlapped with medical issue station. That is number 2 or second format. Number 3 format, we are going to look all 3 formats in the upcoming slides. Number 3 is a scenario and a X-ray or a scenario or a fibroscan, a scenario or a CT scan. These things can be attached with the emergency scenario. So you
You
must
show them. Slide show them.
slide
Slide
show.
show them.
Okay. So there are 3 formats of emergency station. That is plain. I'm going to discuss. This is a BCPS mock test question. This one is a BCPS mock test question. This is a plain question, emergency management station, but some evaluation parts can be included with the emergency station. That is the number 1 format. Next, number 2 format, emergency management can be overlapped with another issue, that is medico-legal issue, medical ethics issue and emergency issue. These 2 things can be combined. And number 3, a picture, a X-ray, CT scan can be attached with the emergency scenario paper. Am I clear? The 3 formats of the emergency station are there. So after looking at the scenario paper, we must not be happy and must look for if there is any other things attached to it, if there is any picture or the management issue is related to any medico-legal issue. Oh. Okay. So this is a issue and this is the scenario. Can you go through the scenario properly? Is it clear? Is it clear?
Yes, ma'am, clear.
Okay. The scenario 1, this is a BCPS mock test question. A 56-year-old man, known case of non-Hodgkin lymphoma on chemotherapy, presented with fever 101 degree Fahrenheit for 1 day and features of shock. His urgent complete blood count showed hemoglobin low, that is 10.2, total count low, 2,200 per cubic millimeter, and neutrophil count 440, less than 500, platelet count towards the lower limit, 155 into 10 to the power 9 liter. So what is the most likely diagnosis? As the patient is on chemotherapy and patient is having a non-Hodgkin's lymphoma.
Neutropenic sepsis. বের কি হলো?
ম্যাডামের একটু নেটওয়ার্কের সমস্যা হয়েছে, তো ম্যাডামের সাথে আমি যোগাযোগ করার চেষ্টা করতেছি, আপনারা একটু সবাই থাকবেন প্লিজ। আপনারা একটু অপেক্ষা করবেন, ম্যাডামের বাসায় কারেন্ট চলে গেছে তো এই জন্য একটু দেরি হচ্ছে।
Assalamualaikum. Extremely sorry because due to electricity problem, I got disconnected. Can you hear me now? Can you hear me now?
Yeah.
আমার
Yes, madam.
ভেঙে ভেঙে আসছে।
ভেঙে ভেঙে আসছে।
কথা স্পষ্ট হচ্ছে না।
Please, Assalamu alaikum.
জি ম্যাডাম।
আমার কথা কি শোনা যাচ্ছে?
জি
শোনা
ম্যাম
যাচ্ছে।
শোনা যাচ্ছে।
কথা শোনা যাচ্ছে, ছবি দেখা যাচ্ছে না।
স্ক্রিন শেয়ার হবে, স্ক্রিনটা শেয়ার হবে। আমি একটু বলছি, আপনারা একটু শুনেন সিনারিওটা। আমরা একটু ডিসকাস করি, আমরা নিজেদের মধ্যে একটু ডিসকাস করি, স্ক্রিনটা এর মধ্যে হচ্ছে শেয়ার করবে। আমি I'm going through this. That is a 56-year-old male with non-Hodgkin's lymphoma, presented with fever and total count hemoglobin low. Total count slide 9. Slide 9. Slide 9. Slide 9. G. Okay. That's okay. And total count low, neutrophil count low. So what is the most likely diagnosis? And it's very clear that it's neutropenic sepsis with shock. And next, what immediate measure you will do? That is, it's an emergency station. So emergency rules or emergency steps that should be followed. That is, here didn't included the ABC format here, but we must include that things in the expected answer, that we should assess the patient, we should do the emergency resuscitation, that is intravenous fluid, IV antibiotics, and the sepsis 6 bundle. And as this is a case of sepsis, we can also answer that we must follow the sepsis 6 bundle. Next slide. Next question was what type of fluid you will, it's an emergency management station, what type of fluid you will start and what
Normal saline, ringer lecture.
it's intravenous crystalloid, not use intravenous crystalloid, normal saline, Ringer's lactate, that is the fluid we use, and the height. And what is our preferred timing and choice of antibiotic? According to the sepsis 6 bundle, we must do the 6 things within 1 hour. So according antibiogram
Can you hear me now?
Yes, ma'am.
Okay. Okay. So, what's the preferred timing of antibiotic and the monitoring issue? And next, what you will do if fever doesn't subside within 48 hours? We have to give the antifungal and antiviral, these things. If the issue related to any clue for antiviral, then we can give antiviral as well. If there is any clue is given, we should give antifungal. But if there is any antiviral
Slide share, please.
is given here, written here in addition antifungal, because if there are any issue, giving antiviral that with herpes simplex encephalitis or any viral encephalitis, patient is having altered consciousness and fever, but there is no drop in blood pressure in the initial stages, because we all know that bacterial superinfection occurs in the settings of viral fever. So antiviral, that's the optional point. We must remember, if that can be included, then we can, any clue to a viral fever, then we can also include these things here. So next slide, slide 11, slide 11. Slide 11. Slide 11. Okay. Slide 11. Okay. What single investigation you will advise for screening of the suspected diagnosis? Screening investigation, serum lactate. After fluid replacement, blood pressure is still low, and which drug you will give now? So if there is blood pressure is still low after the fluid replacement, then we have to give the norepinephrine first. But after the blood pressure is raised to 90/40, capillary refilling time 3 seconds, periphery cool. The blood pressure is raising, but capillary refilling time is still low, periphery is still cool, skin mottling, periphery cool. What investigation is necessary? So we have to look for if there is any sepsis related cardiac involvement. So we have to do next investigation, bedside echo, and which drugs can be needed. That is, if there is a cardiac involvement, then we have to give dobutamine or epinephrine in case of replacing the norepinephrine. So this is the answer given by the BCPS. In case of mock test, there is a little bit difference in Davidson and sepsis 6 bundle. But the usual format is fluid replacement first, then non-epinephrine, and next the management issues goes in 2 ways. That is, if there is cardiac involvement is there, cardiac involvement is not there. If cardiac involvement is there, we have to give epinephrine. And dobutamine issue is given in the mock test, but recent guideline is a little bit difference, and I'm going to give the difference between these 2 things in the next slide. But I didn't alter the BCPS mock test answers because it's given as it is given in the mock test solve class. Next slide. 12. Yes. Next issue, next scenario. Can you hear me? Can you? Am I audible clearly?
Yes, ma'am.
Okay. Next issue, that is a 55-year-old diabetic hypertensive female presented to you with pain, perishing cold, weakness of the left leg for last 3 days. She has no joint pain or legs swelling. So she is having the cold, pain, and weakness in the leg. but there is no pain or swelling. So there is no signs of DVT and there is no signs of arthritis. So for history, that is the evaluation. The previous station was management issue, but here we are dealing with the evaluation issue. The for history, you want to look for the this scenario, that is evidence of atherosclerosis is there or not. If there is any features of vasculitis, SLE or any other vasculitis, any congenital heart disease, if there is any heart failure or arrhythmia that can cause the embolism to the peripheral vessels. So we have to take the 4 histories. This type of scenario is also important for problem-based question in the written and also. So important findings. What are the important findings? Next slide. Slide 13. Slide 13. Slide 13. No, slide 13. Slide 13. One important findings in the general examination. Important finding in the general examination, and important finding is pulselessness, irregular pulse, blackening, pallor, toes affected limb, or if there is any features of xanthelasma. So we have to look for these findings in the general examination. Slide 14. Slide 14. This slide. এই স্লাইডটা দেন, হ্যাঁ স্লাইড 14, হ্যাঁ ঠিক আছে এই স্লাইডটা ঠিক আছে, এই স্লাইডটা দেন, হ্যাঁ। So on examination, the examiner will tell you that the peripheral pulses are absent, ADP of the left leg is pulseless, and what you will search in the in her systemic examination, what you will search, that is paresthesia or paralysis of the leg, other valve abnormalities or shunt abnormalities or other cardiac abnormalities. Immediate management, what immediate management issues can save the limb? What are the immediate issues? As it is a case of acute limb ischemia, what immediate issues should be discussed? That is consult with a vascular surgeon, anticoagulant, bolus heparin, 3,000 to 5,000 unit, antiplatelet, high dose fluid, avoid dehydration. If it's a embolic case, then there is chance to remove the emboli from the vasculature by the vascular surgeons with Fogarty. That's the kind of intervention. They can bring the clot out of the vessel with Fogarty. So that is a vascular surgeon or surgical issue, but we are dealing with the medical issues, anticoagulant, antiplatelet, and another issue, that is streptokinase can be given in the specific vessel. That is also another issue. So these things are given emphasis. So I have write down these things. So, but other 2 options I have already said, that is the removal of the clot by the vascular surgeon with Fogarty, and the specific vessel streptokinase, use of streptokinase in the specific vessel if it can be identified. So these are the plain questions. These are the plain type of plain questions. We all are dealing with the plain questions, the question sheet, the question by the examiner, and the answer by the examiner. Next slide number 17. Now we are going to slide number 17. Go to the slide number 17. Right. And this station, it's not a plain station. This is another format, that is combination of emergency evaluation with medical issue. It's not a plain emergency station. I have already told that if there is any problem in sharing slides, Can you go through the slides properly? If the writings are clear. Combination of emergency evaluation station and medical ethics. The scenario is a 22-year-old female attended the emergency department with history of pain in the lower abdomen and profuse vaginal bleeding. It's obvious that it's a case of abortion. She was accompanied by her fellow mate. Examination revealed pulse 100 beats per minute, regular blood pressure low 80/50 milliliter mercury, and the attended physician admitted her in the hospital. Next slide, 18. Slide 18. Right. What is other clinical findings you have to look for reaching the diagnosis? Mention 6 findings. So 6 findings, as it's a case of abortion, that can be a septic abortion, that can be a sepsis, and there can be hypovolemia as well. So we have to go for these types of findings like pallor, tachycardia, hypotension, hypogastric tenderness. But another important issues that is not related to medicine, but it's related to obstetric, that is product of conception, hanging or active pervaginal bleeding, features of inevitable abortion, oocyst open or not. That is also an important issue in case of abortion. If you don't write down this point, then the marks will be reduced. So if there is any obstetric issue, the moral of the story of this scenario is that if there is an obstetric issue, we have to look for the obstetric findings as well. Next slide, 19. Slide now 19. 19, next slide. Okay, next slide, right. On query, she mentioned that lower LMP was 6+ weeks back, and she took some medicine to regularize her period. After that, she started pain and bleeding. Clinical findings suggestive of inevitable abortion, that is oocyst open, the active bleeding is there. So what should you do now? So she needs urgent evacuation. She needs urgent evacuation under general anesthesia. So we have to call our obstetric fellow colleagues, and in addition, her guardian must be informed about the condition of the patient, as abortion is a medical issue. We all know that it's a medical issue. So we have to write down it as a medical issue, and we can inform their guardians or our fellow mates regarding this. Next slide. Next slide. On further query, she admits that she is unmarried, and she requested the physician not to inform her parents regarding this. What should you do to avoid the medical problem? So the medical issue is there. I should respect the desire of the patient, autonomy of the patient, but I should inform the seniors, head of the department, and write down the medical issue in the document book and the findings, but I must not inform the parents regarding this abortion issue. So this is a combination of complex station, that is medical issue plus emergency issue, combination of this station. Next slide. Next slide. Next slide. Giving emphasis on symptoms is more than going through the disease alone. Chest pain is an important symptom, and everything must be under control regarding this. So chest pain, if there is any symptom, we have to explain the symptom first. Very simple issue. We all know that. Nothing to tell more about these things. If there is a symptom, the patient came with a chest pain, what history you want to take? A patient came to you with a severe upper abdominal pain, what history you want to take? A patient came to you with a sudden severe headache, a sudden visual loss, what you will do? What history you want to take from him or her? So the first thing I should ask, that is the characterization, the explanation of the symptom. Very common issue, very simple issue. We all know that. There is 65-year-old mail came to you with chest pain. So what should I do? The explanation of the type, character, aggravating factor, relevant factor. If you are asked to tell the history, then I should start with the symptom analysis. But if you are asked to tell the immediate steps, so history should not be an immediate step in case of emergency management. We all know that. What is the difference between the emergency management issue and the other non-emergency management issues? Explain the type, character, aggravating, relieving factors. We all know that the past history, very important. If there is any cardiac event, stroke, or if there is any complication regarding chronic limb ischemia, drugs, if he or she is using any drugs, NSAIDs, ecosprin, beta blockers, OCP, cocaine, important because the pulmonary embolism is cocaine, the stimulants drug can cause the MI. So these drugs or recreational drug use is important, and this history should be evaluated. If there is any risk factor, CVD, smoking, family history, if there is any risk factor of DVT or pulmonary embolism, surgery, malignancy involved, this is also important. All the things are important for problem-based questions as well. Relevant medications, I have already told, the hormone replacement or the contraceptive pill. Risk factor for pneumothorax, tall man, if there is any connective tissue disease, Marfan's, smoking history, tuberculosis history. So these things are important for chest pain checklist. And the complications of chest pain, if there is any complications of chest pain, that should be also evaluated in the history. Acute LVF, chest pain, that is followed by a severe respiratory distress, restlessness, arrhythmia, edema, and all the adverse, if there is any drug adverse effect, if there is any anaphylaxis with streptokinase. So these complications history is also included in the history taking. And if it is relevant, we must ask all these things. If there is any symptom relief or the symptom is not relieved after giving the drugs. So differentials of concerns in case of chest pain, that is acute coronary syndrome, unstable angina, or MI. If the troponin levels are given and carefully look at the ECG finding of abnormal, then acute coronary syndrome. So look for the troponin and ECG findings or reports carefully if it's given, or if the examiner in the process of time tells you that the findings are like this: pneumothorax, pneumonia, esophageal spasm or jar, pulmonary embolism, acute pericarditis, myocarditis, dissecting aneurysm, and panic attack. These are the differentials of concern. So next we are going to look for a scenario, and let's have a look at the scenario. Next slide, next slide, next slide. Next slide. Differentials, I have already told. Next slide. The scenario. Next slide. Next slide. Previous slide. Right. This is the scenario. A 30-year-old man presented with sudden severe chest pain and sweating for 3 hours. He was completely okay few hours back and was attending a private party. 1 hour after admission, he became restless. And what are the immediate steps you want to take? So immediate steps, the common steps for immediate or emergency management, that is CABC, rapid assessment and resuscitation. That should be the initial step. Next, urgent investigation, ECG, troponin I, saturation of oxygen. Next, sir can say that you wanted to do a ECG. ECG is showing ST elevation in lateral leads. So when the sir will say that the ECG findings are abnormal, ECG findings are available or not. If the patient came to you with chest pain, then we can give the EcoSprint without looking at the ECG also, because chest pain is a vital issue. And although the ECG is negative, we can give the loading dose. Loading dose aspirin 300 milligram and PCY12 inhibitor. And a difference from previous Davidson issue, that in the previous issue, there is written that we should give aspirin and ticagrelor 180 milligram. But in this issue, we can give any PCY12 inhibitor like clopidogrel or ticagrelor.
ম্যাডাম এটা কি PCY12 নাকি P2Y12 মনে হয়?
P2 PCY12 platelet inhibitor, clopidogrel or ticagrelor, anything can be given. Next, oxygen inhalation, intravenous fluid, cardiac monitoring, metoprolol 5 to 15 milligram IV. Next slide. Oh, previous slide. আগের স্লাইডটা দেন, শেষ হয়নি তো এটা। হ্যাঁ, ঠিক আছে। Oxygen inhalation, this slide. Oxygen inhalation, intravenous fluid, cardiac monitoring, metoprolol 5 to 15 milligram IV or 50 to 100 milligram oral. Initial steps. Next slide. Previous slide. Look for pulse rate. If the pulse rate is low, type of MI, what kind of MI, and in the new Davidson there are types of MI. So we all know that the type 1 MI, when there is atherosclerotic origin, that is type 1 MI, when there is atherosclerosis. So this is a young male and attending a recreational, having a recreational drug in a party. So this patient can have type 2 MI because mismatch between the blood supply and oxygen demand of the heart. If the coronary arteries are constricted with the stimulant drugs or cocaine, there is no atherosclerosis, but the blood supply and the demand of the cardiac mismatch is causing the MI. So there, in case of this patient, there is chance of type 2 MI. Anatomy of the MI, the side of the, if there is MI, we must look for the complications of inferior MI like complete heart or other bradyarrhythmias. If there is any complication in the scenario, we didn't get any concern regarding the other complications, is present or not. So we have to answer the question agglutinating all these things, compiling all these things. After admission, he became restless. There is a concern about complication, as the patient is having chest pain, but the patient was stable. But after admission, after 1 hour, patient became restless. So there is complication. So I have to find out what kind of complication the patient is having now. Next slide. Okay. And next slide. And now what signs I have to give emphasis for this complication, that is patient is having tachycardia is the earliest sign of heart failure, tachycardia. Other low blood pressure that will follow the tachycardia. And next, blood pressure, I will say that, sir, I want to see the pulse, the blood pressure, the heart sound, if there is any murmur, if the JVT is raised or lungs are clear. I have to look for these 6 things. Pulse, because if there is any tachycardia, if there is any bradycardia, if there is any pulselessness, we have to look pulse for this. Blood pressure is low, the patient is having heart failure. Heart sound. What is the importance of heart sound? Heart sound is indistinct. Heart sound is not clearly audible. What is the importance of it? When there is when the sound is not clear, then what can we do when there is third heart sound, fourth heart sound? We can assume that there is a left heart failure. And when the heart sound is indistinct, what can we understand with that sign? Murmur present or not? If the murmur is present, if there is a apical murmur, mitral regurgitation, there is a septal rupture. If there is any murmur, we can say we can assume that there is a mechanical complication. So JVP is raised, the patient is having heart failure, left heart failure or acute LVF. Lungs are clear. When JVP is raised, but the lungs are clear, the patient is not having a acute left ventricular failure. Though this is clear with that the signs. I am going to tell the signs, and the sir will tell me what are the findings. Sir will tell that there is no murmur, the JVP is raised or not, the lungs are clear. Sir will answer that. And from the answers of the sir, I will formulate the next step of answer. What specific sign you will look for? I'll look for pulses. I'll look for previous slide. What specific sign you look for? I look for the sign of pulses paradoxus, because I am assuming that this is a mechanical complication and patient is having cardiac fracture of the wall. And so what is your what investigation you want to do? I want to do a bedside echocardiography. What is diagnosis? Acute myocardial infarction, acute ST elevation myocardial. Actually, it's a acute ST elevation myocardial infarction, anterolateral with cardiac tamponade. What may be the probable etiology? What may be the probable etiology? So, the probable etiology is a cocaine or stimulant drugs causing the MI, the most probable etiology in this case. Next slide. Next slide. Next slide. Okay. Next slide. ঠিক আছে. This slide. Okay. So pulsus paradoxus, how can we diagnose the cardiac tamponade, and what are the findings, what are the signs? That is blood pressure falls when it's a misnomer. Blood pressure falls when the breathing deeply, rapid breathing, heart rate, tachycardia, heart sound are faintly hard or indistinct, neck veins are bulging, distended, and weak or absent peripheral pulses. So if these signs are given, when there is myocardial infarction, we should think about all the complications. We should think about the porta tympani rupture, mechanical complication, heart block, and arrhythmia, ventricular tachycardia. We must think about all the complications. Scenarios can be given about any complications. Next slide. Next slide. Next slide. Okay. Another scenario. That is a 30-year-old pregnant patient presented to you with palpitation and restlessness for 1 hour. She had prior history of recurrent palpitation. On examination, pulse is 160 beats per minute and blood pressure is 80/60 millimeter of mercury. Lungs bilateral crepitations present. ECG on down and showed white complex tachycardia with extreme concordance. Concordance is a findings of ventricular tachycardia, that is extreme right axis deviation or extreme left axis deviation. That is the only R in the upwards or downwards. Extreme concordance. This is a criteria of ventricular tachycardia. So this is not a supraventricular tachycardia that is evident from the ECG finding. So what are the initial states? That is same, the immediate management of B, ABC, shift to the CCU, oxygen inhalation, intravenous line, attached to the cardiac monitors. Next, what steps can you take? There is a medical issue here. The DC cardioversion, we have to take the written consent from the surrogates if they are available, but if it's a emergency and there is no patient surrogates are present, then in case of emergency situation, we can give the DC cardioversion without patient's consent. But if there is any surrogate of the patient is present there, then we can take consent from them. So DC cardioversion 150 to 200 Joule, biphasic shock, and immediate resume CPR, because after DC cardioversion, patient can recover or patient can deteriorate, and assess ABAC, airway, breathing, circulation again. What other drug can be given? Lignocaine and amiodarone. That can be given, and amiodarone bolus, then maintenance dose can be given. After sinus, after becoming the sinus rhythm, the patient again become restless. After becoming the sinus rhythm, the patient again became restless. So what things can be done? If the patient again became restless, if there is any reversible causes, if there is investigations are evident by this time, and if there is any reversible causes, we should treat the reversible causes and maintain the, after bolus, we should maintain the maintenance dose of amiodarone in case of recurrent ventricular tachycardia. And in case of long-term management, if there is no reversible cause and repeated, then ICD can be given. Next, next slide. Next slide. Another important issue of chest pain and dyspnea. Next slide. Next slide. Right. Previous slide. Ager slide. Okay. A 30-year-old female was presented in emergency department with the complaints of sudden severe chest pain with no radiation to neck or arm. She has no fever, cough, diabetes, or hypertension. Blood pressure is 80/60, pulse raised, tachycardic, patient breath sound resonant, and no added sound. So there is breath sound is resonant and no added sound. There is lungs are clear, so patient is not having any acute LVF. When the patient is having chest pain and shortness of breath, there must be some clue for cardiac complication, but there is no other cardiac clue for MI or its complication. And it's a young female and there is no clue for MI also. Next slide. So what is the investigation? Next, the question is what investigation we will do. Next slide. What investigation we will do? The ECG, of course, the ECG, the troponin, the D-dimer, and the X-rays. Bedside or portable X-ray. ECG, the examiner will tell the examiner that there is right bundle block with T inversion in V1 to V4. The examiner will tell you the findings. Next slide. Next slide. Next, you are asked about the 4 other points in the histories that is important for this patient. That is OCP, that is history of thromboembolism, surgery, malignancy, family history of thromboembolism, and leg swelling. Next slide. Next, what 5 signs or what are the physical examination findings you will look for? So it's very obvious that it's a case of pulmonary embolism. From the scenario, we have to assume that this is a case of pulmonary embolism. Every clue, every word is very, maybe some of these words. So what are the 5 signs? That is central cyanosis, raised JVP, loud P2, late hip, leg swing. D-dimer is result is available by this time, and that is 2000 nanogram per ds. Next, what is the diagnosis? Severe. So next step, you want embolism. CT pulmonary angiogram done, and that confirmed that this is a case of pulmonary embolism. Now, what next step I can do? I have to do a duplex study of the Luan-Ling vessel to look for the source of pulmonary embolism. Next slide. Next slide. As the patient is pregnant, what test will help you for diagnosis? Then CTPA, that is when D-dimer is not very pulmonary embolism in case of pregnant woman. Patient is in shock. What is the specific treatment of option for this patient? Thrombolytic therapy, IV, streptokinase. Patient is stabilized after treatment. What are the next treatment options for this patient? That is anticoagulation with low molecular weight heparin and warfarin. Patient cannot be anticoagulated. What can be done? We can give the Caval filter. So this is a management issue and as well. Pulmonary embolism is next slide. Next, we are going to have a compound scenario. That is a 56-year-old male, hypertensive on atenolol or osatin, with severe chest pain which radiates to the back. Blood pressure is 96/53, respiratory rate 20, saturation 96, okay, on normal air 8. And next slide. Right. A X-ray is attached with this scenario. One X-ray is attached with this scenario. Scenario is there, but there is also there can be a pictorial and there can be an X-ray along with this scenario. So after looking at this X-ray, what are the signs we will X-ray, what we will look for? Next slide. Two important physical signs. So two important physical signs are that vascular insufficiency, the pulse deficit, radioradial or radiofemoral delay, or murmur, or the features of tamponade, pulsus paradoxus. Next slide. Next slide. Next slide. So important investigation is ultrasonography, color Doppler echocardiography, or ultrasonography with cardiac probe. When the X-ray is given, then other differentials are literally excluded with this X-ray. So what are the X-ray findings? Next slide, Ajay. Widened mediastinus, left lung field opaque and abnormal aortic contour. So this is a dissecting aortic aneurysm complicated by rupture. Dissecting aneurysm is common in pregnancy after any bypass surgery or CABG, or it can occur with connective tissue disease as well. So if there is any clue, we have to look for the clues very clearly. Next slide. Next slide. Another compound issue. Previous slide. A 49-year-old female with epigastric pain, raised blood pressure 210/90, saturation is okay. Abdomen soft and non-tender. Next slide. One ECG is attached with this scenario. The patient came with severe epigastric pain, blood pressure raised, saturation of oxygen is normal, but one ECG is attached with this scenario. That things can happen. So one ECG is attached with scenario. Next slide. One or two ECGs can be attached with the scenario. Next slide. That is ventricular ectopy are on T phenomenon. Previous slide. And this slide is, so these two ECGs are attached with the scenario. Now the questions are, now, next question. What you are going to do now? As the patient is ROT and patient polymorphic VT, patient is at risk of cardiac arrest, and we have to, what we have to do if the patient is collapsed, we have to do the basic life support and advanced life support. Next slide, next slide, next slide. Basic life support and advanced life support. If there is a scenario of, or if there is any clue for cardiac arrest, this type of VT, VA, polymorphic VT, then we have to, the answer will be basic life support or advanced life support. We all know the algorithm of basic life support and advanced life support. Advanced life support, post cardiac arrest, not for IU. Next slide. Basic, that's what we do, the CPR, assess the rhythm. Is it shockable? Yes, it's shockable. We have to give the shock. Okay. This slide. What are the causes of early mortality? Prognosis. Prognosis depends on the prognosis of the disease. MI. What are the causes of mortality in case of MI? So lethal arrhythmias, cardiogenic shock, rupture of the mitral valve papilla, septal wall rupture. We have already seen this scenario, and aneurysm from the embolic event. Prognosis of the disease. Our one part of the question of station is prognosis of the disease. The prognosis depends on the cardiac arrest, MI Kipling score, hypertension, tachycardia, age, comorbidities, and time to reperfusion. That is, reperfusion is early. If the reperfusion can be given early, the prognosis is good. Next slide. Slide 46. Slide 46. Slide 46. 46. 46. 4-to-1 rule. 4 heart chamber, 4 heart emergencies. There are 4 chambers in the heart, 4 heart emergencies. That is pericardial effusion, 2 lung emergencies, pulmonary embolism and pneumothorax. 1 esophagus, esophageal perfusion. That's not very much important for us. Dyspnea, that is another issue. Next slide. Next slide. Dyspnea is an important issue, and the checklist for dyspnea, that is type, character, dyspnea, pneumonia, fever, chest pain plus dyspnea, MI with complication, diabetes, acetone breath, followed by unconsciousness, diabetic ketoacidosis, COPD plus cough, or history of TB, Marfan's. Diagnosis can be pneumothorax. Past history, asthma, COPD, heart failure, or if there is any inhalation, or if there is drugs, ecosprin beta blockers, there is any drugs, and after that, using that drugs or vaccine, patient develop dyspnea, there is chance of anaphylaxis. Next slide. Next slide. Breath. Bacterial infection or pneumonia are reactive airway diseases, asthma, COPD, anaphylaxis. 3 diseases: embolism, acute coronary syndrome, acidosis, component, H for heart failure, and E for electrical excitation or arrhythmia. These 7 things, breath, pneumonia, these 7 things included all the important issues in any scenario beyond this, these things. Checklist, we have already gone through the checklist. Next slide. Next slide. Slide 52, scenario. 52 তে চলে যাও। Slide 52. 52 এগুলো স্কিপ করেন, সরে চলে যান। Scenario: a 45-year-old male collapsed in the road. He was vaccinated for rabies vaccine few hours ago owing to a dog bite. He was sweating and had dyspnea. So we have gone through the differentials of dyspnea, and the patient is vaccinated for rabies, and patient is having dyspnea and sweating. So very obvious that it's a case of anaphylaxis. 4 immediate steps you want to take. What invasive procedure you can do, supportive measure you can do, adrenaline, in which route we should use adrenaline, if the patient stabilized, what things can be done, and if there is any indication for self-administration of adrenaline. The last question, when you will answer all the questions right clearly, then sir will ask the last question. It's not like OSPI that all the questions are given at the same time. When you can answer all the questions correctly, then you will get the last question. You will not get the last question first. Next slide. What the immediate steps? A, B, C, D. The step: emergency resuscitation and assessment. Ensure the airway patency. IM adrenaline 1:1000 dilution 0.3 to 1 ml. May need repeated dose and oxygen inhalation. The invasive procedure is tracheostomy. We can have to do the tracheostomy due to laryngeal spasm. In other things, we can use hydrocortisone, chlorphoramine, nebulized beta-2 agonist, and nebulized adrenaline. That is newly added nebulized adrenaline. We can give these things to reduce the bronchospasm. IV fluid for hypotension. Next slide. Next slide. Which route we use? We use IM route, because IV route is we don't use IV route because due to vasoconstriction. Vasoconstriction can occur. That's why we use IM route in case of adrenaline. We all know that adrenaline causes vasospasm. Self-administration of adrenaline. The indications are anaphylaxis, difficult to avoid, idiopathic cause, history of localized reaction, high risk anaphylaxis, severe localized reaction, adverse outcome, or poorly controlled asthma, lack of emergency care. In that things we can use the self-administration of adrenaline in case of anaphylaxis. Okay, next slide 56, slide number 56. There is a picture regarding anaphylaxis. We have to memorize this picture. picture for the symptoms and signs of anaphylaxis like conjunctival congestion, flushing, sweating, wheezing, hypotension, urticaria, spring, cardiac arrhythmias, angioedema, and diarrhea. All the things can happen, itching. So this picture is a very important picture for memorizing the signs of anaphylaxis altogether. 57. 57. And next, this is a broad type of question. A 20-year-old farmer was taken to the emergency and complained about sweating, flushing, stridor, and hypotension. Anything can happen. Sweating, flushing, stridor, hypotension. There are so many differentials with this complaint. So it's not indicating any specific disease. So what are the histories you are going to take? History of any food, peanuts, milk, soybean, bee or whisk bite, snake bite, drugs, detailed history in last 24 hours, previous history of such event, wheezing, facial edema, palpitation, family history, chest pain or dyspnea, other things, respiratory symptoms and cardiac symptoms. Next slide. And what are signs you look for? Next slide. Slide 58. Conjunctival congestion, wheeze, grip sting, arrhythmia, all are the signs that is shown in the picture. 4 drugs that can cause type of situation, that is NSAIDs, radiocontrast media, SA inhibitor, ARB, and opioids. Previous slide. Again slide. Again slide. Again slide. Slide 58. Slide 58. Which systemic disease can be related to this? So hypothyroidism can be related with anaphylaxis. 3 differentials. What are the differentials that we can consider for flushing stridor? We can 56, slide number 56. Right. Immediate investigation. When IgE level is very much high, what other test you can prescribe? That is mast cell prick test and specific IgE level and skin prick test. So this is actually the evaluation of angioedema when all the angioedemas doesn't lead to anaphylaxis. When angioedema is severe, that can lead to anaphylaxis. Next slide. Next slide. Next slide. Next slide is going to deal with another important issue. Now we are dealing with the evaluation and management issue, but actually this is a respiratory management issue. This slide. Acute medicine chapter, respiratory management issue, circulatory management issue, these things are discussed. So this is a respiratory management issue. A 45-year-old woman was tested positive for COVID and she is having severe COVID trachypnea. Patient is having temperature, pulse rate high, respiratory rate high, blood pressure is in the lower limit, oxygen saturation is low, 90%. So how we can give her respiratory support? Next slide. Next slide. How we can give the respiratory support? So at first we should give the oxygen with the nasal cannula. The oxygen is given with nasal cannula with 5 liters per minute for 20 minutes, but the patient is not responding and the patient is getting hoarse. So next, what we can do? We can give oxygen from 2 to 5 liters through nasal cannula. Next, we have to use the face mask. So face mask we can give 6 liters to 10 liters of oxygen. And sir will ask how much oxygen I can give through face mask, how much I can give oxygen I can give through non-rebreathing mask or partial non-rebreathing mask. So partial rebreathing mask we can give with reservoir we can give 15 liter per minute, and non-rebreathing mask with reservoir up to 15 liter per minute. Next slide. Next, Venturi mask is not available in our country. Next slide. Next, we can escape the Venturi mask because Venturi mask is not available in many parts of our country. But as given in the guideline, we can tell the answer as Venturi mask. We can give mask with fixed rate and high flow. And high flow nasal cannula, we can give 30 liters to 70 liters. High flow nasal cannula, up to 70 liters we can give through high flow nasal cannula. Despite the high flow nasal cannula, or one day all the vitals deteriorated, oxygen saturation is getting low, then we can use the CPAP and BiPAP. And if it's failed, we can give the intubation and mechanical ventilation. Next slide. Next slide. Next slide. Previous slide. Previous slide. So first nasal cannula, then face mask, then partial no rebreathing mask with reservoir, partial rebreathing mask, next Venturi mask, next high flow nasal cannula, next CPAP, BiPAP, and then mechanical intubation. So these are the steps for respiratory support. And these things can also come in the recent update chapter, the respiratory recent advances in the respiratory management. Okay. Next, I'm going to the next slide. I must go fast. The next scenario. The next scenario is a 50-year-old lady presented with fever and diarrhea. This is a scenario from infectious disease. Must not forget the emergencies related to infectious disease. Infectious diseases are very much favorite for many teachers, and some teachers are malaria prone, some teachers are examiners are dengue prone, some examiners are COVID prone. So infectious diseases and its emergencies must be properly taken care. A 50-year-old lady presented with fever and diarrhea for 5 days. She developed severe respiratory distress 2 days after admission. The presenting complaints are fever and diarrhea. She had a history of traveling to Rangamati. Her ICT for malaria test is positive. Her saturation is 60%, and there is no history of fluid infusion. So there is no history of fluid infusion. There is no chance of fluid overload. So what has happened? What's the problem for which the patient is deteriorating? That is, our saturation is low. The single most investigation you want to do to find out the cause of dyspnea, that is X-ray chest posterior with portable, to look for the ARDS. Dengue and malaria and COVID causes ARDS. We must remember these things. And another important issue, that is acute pancreatitis causes ARDS. And the examiner will say that you want to do the X-ray. The X-ray findings are positive, bilateral, non-homogeneous opposites in all zones of the both lungs. What immediate steps you want to do now? That is, I want to give the respiratory support, high flow nasal cannula. As the saturation is very low, I must not tell that I will give oxygen through nasal cannula or face mask. So I directly go to the high flow nasal cannula or intubation, prone positioning as it's a ARDS, anti-malarial drugs. What other drugs can be beneficial? That is, it's the management of ARDS. It's the management of ARDS, muscle relaxants, diuretics, fluid management, fluid restriction. Dry lung is good for ARDS, steroids, and what special oxygen delivery can be given? That is ECMO, extracorporeal membrane oxygenation. This can be given. I am not telling the management of ARDS of COVID. ARDS described in the acute medicine chapter. ARDS is a separate entity other than the COVID. And in case of, if there is any clue that this is a case of ARDS, when there is dengue, there can be ARDS. When there is one, that can be ARDS and pain. But patient developed severe respiratory distress 2 or 3 days after the admission. What happened? The patient developed ARDS. ARDS is not actually infective cause, it's actually inflammatory cause. The excessive inflammation process provoked by the any trigger causes inflammation of the both the lungs. So the mechanism or pathophysiology of the ARDS is actually a inflammation, not the infection. The next issue is coma. That is next slide. Coma. Next slide. Coma. Next slide. Right. 64. Huge differentials of coma. The differentials of coma and delirium are same. But the important issues, the metabolic causes, the hyponectemia, adrenal failure, hypercalcemia, warnings disease after alcohol injection or alcoholic person is there is any clue of alcoholism, must look for if there is any clue for warning disease, sepsis, drug overdose, abuse, lots of drugs, poisons that can cause coma, hypothermia, and other causes, renal, liver failure, that also can also cause coma. And the infective causes are there as well, because meningitis, cerebral malaria, and encephalitis, all the infective causes, they can also cause coma. So checklist for coma. Next slide. Next slide. Hemiparesis, ptosis, vomiting, headache, hypertension, 6-nerve palsy. Coma checklist, right? This one. Hemiparesis, ptosis, vomiting, headache, hypertension, 6-nerve palsy. And these are the clues for subarachnoid hemorrhage. There can be intracerebral hemorrhage as well. When there is 6-nerve palsy, we must look for any clue of subarachnoid hemorrhage is there. Other clue related to renal polycystic kidney disease, or if there is any other clue which is giving the clue for alcohol, suicide, any cycle. The stimulant drugs are the stimulant drugs that can cause the intracerebral hemorrhage and myocardial infarction. Both the events can occur with these drugs. One policeman died after one huge propaganda after policeman died from mental hospital in a private hospital. So if he has any he has taken any stimulant drug, then there can be a chance of MI, sudden death. So we must look for the use of drug very carefully. Road poisoning, pickpocket, brass table, accident, any pickpocket or any road poisoning that can cause coma, fever, rash, meningitis, encephalitis, liver, kidney disease, diabetes, hypoglycemia, insulin, thyroid disease, adrenal disease. So if we look for all the things, we will get the diagnosis. Next, another scenario. Next, another scenario. Next, another scenario. Next. Next, another scenario, that is a 60-year-old diabetic hypertensive male was found unconscious in road. His neighbors brought the man to the emergency department. What are the immediate signs you would have attempted in this case? Immediate signs, not the history. What are the immediate signs? So what are the immediate signs? That is pulse, blood pressure, respiratory rate, pupil, very much important, GCS, Focal sign, fever and smell, if there is any smell, as the patient was found unconscious in the road, if there is any chance of roadside poisoning. So the examiner response by the examiner, that is pulse rate 50, blood pressure raised 220 by 80, and respiratory rate is low, constricted pinpoint pupil, plantar extensor, bilateral extensor. So these are the finding, and GCS is low, 6 by 15. Sir will answer all the things. What are the other history you want to look for? If the hypertension, duration control, drugs, injectable drug abuse, if there is any pickpocket, renal disease, liver disease, insulin intake, anticoagulant, previous stroke, seizures, headache, if anything happened along with this. So no renal disease, liver disease, no drug abuse and hypertension for 5 years. Next slide, next slide, next slide, next slide. Okay. His GCS improved. His GCS improved to 11. What signs you want to look now? His GCS improved. Okay, plantar extensor, any focal sign. No, any focal sign. Examiner didn't answer about any focal sign. You have to ask the examiner about. Next slide, slide number 67. 67. কত number slide চলে গেছে? Slide 67. Right, 67. And the sir will say that the patient is having quadriparesis. His GCS improved, but the patient is having quadriparesis. And what are the signs you will look for? The pupil, what's the condition of the pupil? The patient's GCS is low. GCS was very low, and the pupils are pinpoint. So what are the signs you look for? This is improved. What are the signs you look for? That is quadriparesis and cranial nerve pulse. When the pupils are pinpoint and the other histories are negative, and the patient having high blood pressure, pinpoint pupil, and other signs, focal signs, there is when the blood pressure is raised, there is chance of CNS involvement. So what are the other signs you will look for? When there is pinpoint pupil and the patient is having reduced consciousness, we are looking for our posterior fossa stroke. So the stroke, when it will involve the consciousness area of the brain, that is posterior fossa, then we can assume that the patient is having pinpoint pupil and loss of consciousness. So other signs we look for quadriparesis and cranial nerve pulses. 1 by 5 in all limbs, and eye opening normal. Eye opening is normal. No hoche, there is no third or fourth, not third, fourth, but pupils are pinpoint. What are the bedside investigation? You can do saturation of oxygen and blood sugar. What investigations are CT scan brain, of course CT scan of brain, and you will get hemorrhage in the brainstem. So what is your diagnosis now? From the clinical features, the patient is having quadriparesis, patient is having consciousness. So we can tell that in syndrome. And cause of pinpoint people, involvement of the basic and paraclinical sciences, the pathophysiology of this involvement of the sympathetic nerve and its supply impairment. And this is the scenario. I have discussed the scenarios. There are some other another important issue I want to discuss with you. Slide 70. Slide 70. Slide 70. Slide 70. Slide 70. Slide 70 টা একটু দেন। Slide 70 টা right. Uh, 70 next slide. 71 slide. 71 CT scan there, check the CT scan. Right. And if this CT scan is attached with the scenario that a 60-year-old male came to you with loss of consciousness, and this CT scan is given, and the answers are asked that describe the CT scan, that will not be the question, and the CT scan is prescribed for your understanding that the hypotenuse area, frontal lobe, midline shift, perilesional edema, acute frontal lobe hemorrhage with pressure effect. What is the pathology? The moral of the story of this question is, what is the pathology of this hemorrhage? That is amyloid angiopathy. This is the main pathology causing actually hemorrhage, age-related or vascular cause. And other causes, other pathologies can be asked, right? Like AV malformation, aneurysm, tumor, coagulopathy, and maybe location of the common locations can be asked. That what are the common bleeding hemorrhagic stroke areas? That is basal ganglia, cerebellum, and pulse. Common areas. So pathophysiology, basic and paraclinical science, all the formats regarding the emergency questions. There are other issues. There is another class regarding the emergency issues. So next class will be discuss the other issues also. So this is the end of the format of emergency issues and scenarios and their problems. If you have any question, you can ask, and we can discuss the important issues. We all can learn from each other. PDF of the slide will be available in the DCA. Next, if you have any queries, you can ask now if there is any queries, because I don't have electricity in my home now, and the all the charging availabilities are not available now. So if you want to ask any query, you can ask me, or you can write down it in the group or in the Facebook group or WhatsApp group, anything.
এই সিটি স্ক্যানটা কি
Okay.
দেখে আমরা এনজিওপ্যাথি পক্ষে আমরা কি পাচ্ছি এখান থেকে?
Amyloid angiopathy. Amyloid angiopathy is the commonmost cause, vascular cause. The age-related cause, hypertension is one important cause. Amyloid angiopathy and hypertension.
বয়সটা কত ছিল পেশেন্টের?
What is the query?
মানে পেশেন্টের বয়সটা কত ছিল? এজ
বয়স 60 year. Age 60 year. Patient came to you with, and this is a frontal lobe. This is not an area for hypertensive hemorrhage. So what is the area? This is important. If you get the hypertensive hemorrhage area, then I have to tell what are the other risk factors, history or anything. But it's a frontal lobe. It's not a actually hypertensive hemorrhagic area. So the pathology is different. Which area of the brain is involved, and the etiology will differ according to that cause. In case of elderly, the amyloid angiopathy or vascular cause, this is the most common cause causing the intracerebral hemorrhage.
Could it be a case of meningioma? As the second slide, we have seen that there is a highly contrast gain when there is taking contrast. So could it be a case of meningioma?
Meningioma, because
also found
it's
there is
not
a
attached
dural
to the
tail is also
meninges
there.
actually. There is perilesional edema, but the perilesional edema is not much, but it's totally different. It's totally detached from the meninges.
But এখানে
It's
একটু
totally
dual
detached from the
tail
meninges.
midline পাশাপাশি আছে 1 নম্বর 2 নম্বর হচ্ছে dual tail দেখতে পাচ্ছি আমরা, তো এটা তো এবং কন্ট্রাস্ট গেইন করলো, সো এটা কি মেনিনজিওমার পক্ষে তো যাচ্ছে মনে হয়।
Meningioma will cause coma, sudden onset coma. That is, meningioma will be excluded from the initial scenario. Meningioma will not cause coma. It's not a common scenario. I have to think that it's a intracerebral hemorrhage. I have to think common things and common presentation first. It's not attached to the meninges actually. The perilesional edema, this area, this is a in the second slide, it looks a little bit like it's attached to the meninges, but the first slide shows that it's totally detached from the meninges. It's not at all attached with the meninges. And if the scenario is related to meningioma, parasagittal meningioma is there, but if it can cause coma, then it have to be very much large in size and bilateral, and only these things can't cause coma.
By CR.
Hello. Anything you want to add? Anything? Yes, we all can learn from each other. Your point is right, but as the scenario is not like this, and the initial CT scan is not like this, and it's an emergency station, so we must not think that I will get a meningioma in the emergency station. I will think that coma, I will get the common things. Okay. Okay. I think thank you all for your patience hearing. I have taken too much time, I think. Is there any other queries or any other things you can add to this? It's not clear what is written regarding. Okay. Is there anything you want to add? Is there anything you want to add? Any important issues you can arise here? I don't think there is much issues left now, and the next session will make up all the other issues. There are important issues regarding bleeding, seizure, electrolyte imbalance, all the other seizure. There are other scenarios related to the emergency stations, but I have discussed the important and formats of the emergency issues. Thank you, everyone. Thank you for your patience hearing. Tomorrow, I will share with you the new guideline, that is National Guideline for Management of Animal Bite, which is published in December 2022. And this guideline can be asked in the recent update issues. So tomorrow at 9 p.m., I am going to share the important issues of that guideline, as it's not a much discussed issue, but we all can learn, we all can share our things within a very short time, 15 minutes. It will not take much time. 10 to 15 minutes we can discuss that guideline within that time. So thank you very much. I am taking leave from here. এখন থ্যাংক ইউ ভেরি মাচ। শেয়ার কি স্টপ করবেন? রহিম ভাই তো
জি
নেই।
ম্যাম,
জি জি
ম্যাম আছি ম্যাম, আসসালামু আলাইকুম।
জি জি, ওয়ালাইকুম সালাম। রহিম ভাই চলে আসছেন?
ম্যাম আছি ম্যাম, বাসায় আছি ম্যাডাম আমি।
ও আচ্ছা আচ্ছা, বাসায় আছেন। আচ্ছা আচ্ছা রহিম ভাই, আচ্ছা ভালো
ম্যাম,
আছেন তো
আমি
রহিম ভাই?
আজকে
জি জি জি,
আছি,
ভালো
ভালো
আছেন।
আছি
জি রহিম ভাই,
ম্যাডাম।
তাহলে জি
জি জি, আজকে করি
আমরা
ম্যাডাম।
তাহলে সেশনটা এখানে শেষ করি।
জি
সবাইকে
জি
অনেক
জি,
ধন্যবাদ। রহিম ভাইও অসুস্থতা নিয়েও জয়েন করেছেন, রহিম ভাইকে অনেক ধন্যবাদ। উনি অনেক কষ্ট করেন ডিসি এর জন্য। আমরা কোনো বিষয়গুলো আমরা আবার আলোচনা করব। আমি এখানেই শেষ করছি।
জি
রহিম ভাই তাহলে স্টপ
জি ম্যাম।
করে দেন। হ্যাঁ
জি ম্যাম, আজকে হ্যাঁ স্টপ করি। আজকে আমাদের ক্লাসে দায়িত্ব ছিল ম্যাম আমাদের মমিনুর রহমান, উনি দেখাশোনা করছেন, আমি একটু বাইরে ছিলাম,
ও
থাকতে
আচ্ছা
পারি
আচ্ছা,
নাই।
ঠিক আছে। মমিন ভাই,
জি
মমিন
জি
ভাই কি আছেন?
জি,
তাহলে মমিন ভাই
হ্যাঁ আছি।
স্টপ করতে পারেন এখন।
জি জি, মোমেন তাহলে স্টপ
জি
করেন
জি
আপনি আজকে।
জি
জি, থ্যাংক
জি
ইউ সো
জি
মাচ ম্যাম।
জি জি ধন্যবাদ।